definition for AKI, but the one I've just written is just that AKI is a condition which is characterized by abrupt deterioration in kidney function and manifested by increase in serum creatinine levels with or without urine output. Okay, then the other thing you have to also notice, we have to know the the etiology, the classification of the same etiology we are talking about. Okay, then before we go to that, you have to know that the other way you can define the other way you can define AKI is that you can say this is a rapid decrease in glomerular filtration that results in abnormal fluid and electrolyte balance and azotemia. So azotemia is just an increase in waste nitrogen and creatinine. Okay, then you also have to know that the AKI diagnosis is usually has to do with an increase in serum creatinine, which is increases abruptly. Okay, and the increase in creatinine is as a result of a reduction in hydrostatic pressure or accumulative increase in colloid pressure or fluid pressure. So as a result, there is a reduction in glomerular filtration, which will lead to accumulation of creatinine serum, which will lead to an accumulation of creatinine in the serum because it is not being filtered by the glomerulus, secreted into the tubules. So those are some of the things you have to know about AKI. Okay, then etiology, we said down the etiology. There is a classification for etiology. There is a classification number 1 for the prerenal. So you can say under the causes of AKI, we have the prerenal, the renal, and the postrenal. So prerenal, we can have hypovolemia. Okay, so hypovolemia. We can also have reduced cardiac output. We can also reduce cardiac output. Okay, so reduced cardiac output, for example, in cardiogenic shock, it can cause someone to have so in cardiogenic shock can cause someone to have AKI. Okay, then moving on again, we can also, under the prerenal, we can also have a major hemorrhage. So major hemorrhage, which of course is just blood loss. Okay, so which is just blood loss. Can also have vomiting. Okay, we can also have severe burns. So severe burns. Okay, so the pathophysiology for severe burns is that I won't necessarily go into details, but you have to know that when someone is burnt, there is also, of course, there will be release of inflammatory markers such as cytokines, interleukin 2, 4. Okay, so when those inflammatory markers are released, there will be an increase in the capillary permeability. So when there is increase in capillary permeability, there will be a shift of fluid from the intracellular to the extracellular, hence causing hypovolemia, hence causing intracellular hypovolemia, where most of the fluid are going in the interstitial spaces, and intracellularly, or the patient will end up having hypovolemic shock in burns. That's why we don't necessarily even give blood in the first 24 hours. Okay, then even diarrhea can give someone prerenal AKI. Okay, so we can even have GI fluid losses. So GI fluid losses, of course, even vomiting can fall under the GI fluid levels, fluid losses. Even diarrhea. We can also have renal artery stenosis. So renal artery stenosis as an example. Okay, then you can also have reduction in effective circulatory volume. For example, in conditions such as congestive heart failure, liver failure, distributive shock, pulmonary hypertension, those are some of the things. Even sepsis, they can lead to a reduced circulatory failure. Okay, then these causes lead to reduced blood flow into the kidney. So when you have a reduced hydrostatic pressure, then you usually get reduced glomerular filtration. Okay, then you can also have the other point you can also have is impaired renal regulation, autoregulation, due to the use of nephrotoxins such as, so they are drugs which we consider to be nephrotoxic, which lead to impaired renal autoregulation. So nephrotoxic drugs leading to impaired renal autoregulation. Leading to autoregulation. Okay, so those drugs include we have NSAIDs. So we have NSAIDs one. So NSAIDs they actually cause vasoconstriction to the afferent artery, and so it results in reduced hydrostatic pressure, which of course is going to result in reduction in glomerular filtration. Okay, so the NSAIDs causes vasoconstriction to the afferent artery, okay, which result in the reduced hydrostatic pressure, which end up resulting in reduction in glomerular filtration. Okay, then apart from NSAIDs, you can have ACE inhibitors, we can have ARBs. Okay, so these ACE inhibitors and ARBs, they cause vasodilatation of the efferent arteries, which reduces the hydrostatic pressure and reduces the glomerular filtration in AKI. Okay, those are some of the things you have to know about this condition. So the ACE inhibitors, ARBs, they just cause vasodilatation of the efferent arteries, thereby reducing the hydrostatic pressure and reducing the glomerular filtration in AKI. Then other drugs which are nephrotoxic, we can have cyclosporins. So cyclosporin. Okay, so cyclosporin. Okay, so prerenal AKI is very reversible, but if there is a prolonged prerenal AKI, it can lead to ischemia, hence it can even cause permanent damage, but it's usually reversible. Okay, then we go now to the second. So this was the first etiology. Then the second one is the intrarenal. So intrarenal, or we just call it renal. So we have prerenal, renal, and postrenal. So under the renal, we can have glomerulonephritis, glomerulonephritis. Can have glomerulonephritis. So under glomerulonephritis, there are a lot of conditions such as nephritic syndrome, glomerulonephritis. We can also we have nephritic syndrome. We can have nephritic glomerulonephritis. Those are some of the things you actually have to know about the glomerulonephritis. Okay, because nephrotic syndrome alone can't necessarily lead to depending on what's causing it, but if you combine the nephritic syndrome, the nephritic glomerulonephritis, it might cause a renal AKI. Okay, Then apart from the glomerulonephritis, the GN condition or GN, you can also have, so under the GN we gave examples to say you can have nephritic, nephritic syndrome, then you can have nephritic glomerulonephritis. Okay, those are some of the things. Then you can also have a tubular diseases. So tubular diseases such as so under tubular diseases we can have acute tubular necrosis, which of course results from prolonged ischemia from the prerenal AKI. So you can end up having acute tubular necrosis. Okay, this is what can happen if someone is has prolonged ischemia from the prerenal AKI. Okay, but of course even in the same infections, the nephrotoxins are part of the things which can cause the prerenal AKI. Okay, then the other condition we can have is the interstitial diseases. So interstitial disease. Okay, so interstitial disease such as acute interstitial nephritis. So acute interstitial nephritis. Acute interstitial nephritis. Okay, then the other conditions we can have, so the acute interstitial nephritis can also come in due to maybe ischemia, infection, nephrotoxins, connective tissue diseases. Those are some of the things can cause acute interstitial nephritis. So ischemia, infection, nephrotoxins, and connective tissue disease. Okay, so we can have conditions related to the vesicular. So we are actually looking at, if you are following, we are dividing the renal system. So we started from the glomerular, we now went to the tubular, we now went to the interstitial. Okay, so from the interstitial, so this is supposed to be interstitial. So those are some of the things you have to know about the renal. So you can just divide them from glomerular, tubular, interstitial, and vascular. So under vascular, you can have a vasculitis. So vasculitis. Okay, so then the other thing you have to know, we can also have microangiopathic hemolytic anemia, so such as TTP and HUS. So those ones can fall here. Then you can also have a renal thrombosis under the same vascular causes. So the microangiopathic hemolytic anemia, so the TPP, HUS. Okay, can also have a renal thrombosis. Okay, then that's all on the renal causes. Then we can now go to the postrenal causes. So the postrenal causes, we can have renal stones. So we can have renal stones which can cause obstruction along the ureter, which can lead to dilatation of the ureter proximally. So when of course there is obstruction in the ureter proximally, they can also lead to build up of the same excreted products, which can lead to hydronephrosis. Okay, then the other cause we can have is a prostate enlargement. So prostate enlargement. So prostate enlargement. So prostate enlargement. Even BPH you can put. So BPH. Okay, can have prostate cancer. Can have cervical cancer. Okay, cervical cancer can have a bladder CA. So bladder CS. Okay. Then of course postrenal causes can lead to intrarenal causes of AKI, because of course the obstruction or infection occurs. The urine can even be pushed upwards, causing injury to the nephrons and increasing serum creatinine. So remember what we said. So we said the prerenal can cause renal, then the postrenal can also again cause renal again. Okay. So those are some of the things you have to know about. You have to know about the causes for AKI. Okay. Then we can now talk about the pathophysiology. So pathophysiology. Okay. So pathophysiology of this, but we are just going to concentrate on the intrarenal pathophysiology. So the intrarenal one. Okay. So the pathophysiology is that with prolonged prerenal AKI, we said of course there's going to be ischemia, which will lead to tubular disease. So when the tubular disease or injury sets in, the injured tubular cells from the epithelial casts, from the epithelium, from the epithelial casts, which will result in inflammatory reactions, whereby there is an increase in adhesion molecules and leukocytes activation. The neutrophils are also going to be recruited to the area and further perpetuates the inflammatory response, injuring the tubules further. Okay, so it's the reactions which by the neutrophils which are recruited, which end up again causing injury to the tubules. Okay, so this will cause further damage, like I said, to the tubes and the surrounding area, including the interstitium. Okay, the leukocytes are the one which are going to form white cell casts in the glomerulonephritis. Then the red blood cells can also pass through. They can also pass through as a filtrate and form RBC casts. And of course, these things can be seen in the urine microscopy, and even just even just in simple glomerular injury as well. Okay, so those are some of the things on the pathophysiology which you have to know if the problem is intrarenal, okay, or the problem was prerenal, which will lead to an ischemia, which lead to the tubular disease. Then from the tubular, that's when now the renal pathophysiology comes in, where we have the tubular injury. Then the injured tubular cells form what they call epithelial casts, which will result in inflammatory reaction, whereby there is an increase in adhesion molecules and leukocyte activation. Okay, then when the neutrophils are recruited to the area, there will be further perpetuation of the inflammatory response, which of course will lead to injuring the tubules. So that thing will cause further damage to the tubes and surrounding areas, including the interstitium. Then we also talked of why there is white cell casts and there are BC casts on the microscopy. Okay, because we said the leukocytes form white cell casts, then the RBCs, since they can pass through they can pass through the filtrates, they also form RBC casts. So basically that's the pathophysiology about the intrarenal pathophysiology. Then for the postrenal, just the same. If it's the nephrotoxins which are causing the prerenal, if it's the toxins which are causing the prerenal, you also have to know that the nephrotoxins can also directly injure the tubes or interstitium. So there's no need of us again going back and forth. Okay, but you just have to bear in mind that the nephrotoxins, we said of NSAIDs, they are outdated contrasts, aminoglycosides, crystals, myoglobin. You can also have a myeloma, heavy metals such as lead. Those things can cause damage. Okay, then investigations. So investigations, we can have lab and radiology. So lab and radiology. Okay. Then under lab, we can have, of course, full blood count. We can have urea, uh, electrolytes, and grade 9. Okay, which of course, but by now you know that is going to be an increase in grade 9, but also there will be an increase in urea and increase in nitrogen, since we talked of azotemia. Okay, then those are some of the things you have to know about the baseline investigations. Okay, then if the cause was prerenal in origin, then you can request for fluid status, whether it's hypovolemia or hypervolemia. Okay, then it's for if the cause was intrarenal, then you can request for urinalysis, urine MCS, urine cast, renal ultrasound, urine protein creatinine ratio, or albumin creatinine ratio. Okay, those are some of the things you can do, but I'll just put them as lab. I won't necessarily put them so urinalysis, yeah, urine MCS, uh, urine microscopy. Okay, so you can do urine MCS, then you can do a renal ultrasound, under the radiology. So renal ultrasound under the radiology. Then you can also do under the lab, you can do a urine PCR, but the PCR is not for polymerase chain reaction, it's for the protein creatinine ratio. Then you can also do a urine ACR, which is an albumin creatinine ratio. Okay, you can also do a bladder scan on the radiology investigations. So bladder scan. Then you can also do a CT, kidney ureter bladder, CT, even a renal tube, even a renal tract ultrasound. So you can even do a CT KUB. Okay. So basically, those are some of the investigations you have to know. Okay. Then in terms of management, of course, management depends on the cause, and essentially, that's the management you have to know. Okay. Then you also have to understand that IV fluids, if it's the prerenal cause, and if the patient is hypovolemic, you can use IV fluids. Okay, then diuretics, if they have fluid overload, to help clear the fluids. If it's nephrotoxins, you have to stop the nephrotoxins. Then of course, in short, just have to treat the underlying cause. So treat the underlying cause or the precipitating factor. If it's infection, of course, you have to treat the infection. If it's renal stones, you can treat the pain. You can even do a stone removal. If it's an obstructed catheter, you can flush. Okay. If it's electrolyte imbalance, you can treat underlying electrolyte imbalance complications. Okay. Then those are some of the things you actually have to know. Then under the same, we find that people would want you to take for dialysis, but we should know the indications for dialysis. So it's not all patients that you take for dialysis. Yeah, you have to know who to take for dialysis, and of course even when to take for dialysis. Okay. Then the other thing you have to know is that you also have to calculate the creatinine clearance as well. So of course, which will be decreased. Okay. Then before maybe we talk about the dialysis, on the pathophysiology, or just after the pathophysiology, or after the investigations, I just want to mention the symptoms. So after investigations, then clinical presentation. So clinical presentation. So under clinical presentation, of course, we can have the peripheral edema. Then we can also have weight gain. We can have nausea, vomiting, diarrhea, anorexia. mental status change, fatigue, shortness of breath. Okay, so fatigue, shortness of breath. Like there are a lot of clinical presentations, but at least you should know which patient to suspect and which patient to not suspect. Okay, then even reduced patient will be talking about maybe not necessarily going to urinate regularly, so there will be infrequency. Okay, then now we can go back to the dialysis now. So before you even do a management you take to dialysis, you have to look at the indications for dialysis. So indications for dialysis. So in short, dialysis can be as a management. So but you have to know the indications for dialysis. So when do we actually take the patients for dialysis? So indications for dialysis, there is a famous mnemonic R A E O U. So those are some of the things you can use. So A for acidosis. Okay, so A for acidosis, and E for electrolytes, then I for intoxication, then O for overload, then U for uremia. Okay, so overload is with fluids, then acidosis, as the name suggests, so there is no necessarily acidosis, so it can be refractory acidosis, or those are some of the things you have to know. So the acidosis should be refractory acidosis. Then electrolytes, you have to know, we are talking about electrolyte imbalance. So we are talking about electrolyte imbalance, and under electrolyte imbalance can have a refractory electrolyte imbalance or severe hyperkalemia, okay, or hypermagnesemia. Okay, then we can have intoxication. Under intoxication again, there is also another mnemonic which, if I'm not mistaken, is slime. For salicylic acid. Then the L is for lithium, the I is for isopropanol, then the M is for magnesium laxatives. That's the M, magnesium laxatives. Then the E is ethylene glycol. If someone has intoxication to these things, that's also an indication for it's an indication for dialysis. Okay, so let me just change here, indication for dialysis, not diagnosis. So dialysis. Then O is for overload with fluids. So it can be postoperative fluids or just any fluids. Someone was overloaded with fluids can even do dialysis. So overload with fluids. Okay, then the other is uremia. So uremia, we can have uremic complications, so accumulation of uremic toxins, so it can be, which can even lead to pericarditis, platelet dysfunction, which may even lead to bleeding. Okay, so someone has uremia and they present with uremic complications. Okay, those are some of the things you have to know. Okay, then that's basically the end of the presentation. But before we close, we have to know about LIFO. There is no learning AKI without knowing the LIFO criteria. Okay, so the LIFO criteria, as the name suggests, we have two criteria that we usually look at. So of course we have the, let me just put some space. So we have creatinine. So we have the creatinine criteria. You also have the urine output, criteria. Then you have the RIFLE. So the RIFO. So R is for risk. So the risk is that when someone has an increased creatinine, So the creatinine is just increased by 1.5, but the urine output is less than the urine output is less than 0.5. So the urine output is less than 0.5 mil per kg per hour. Okay, per kg per hour. Okay, and you have, before you know the abnormal, you have to know then what's the normal urine output per kg per hour. Okay, that's the thing here. Okay, but this one should happen in 6 hours. Okay, it should happen in 6 hours. Then under the eye, which is the injury, so the eye is for injury. Then the same injury, you expect the creatinine to be increased at least 2 times. So at least 2 times. Then the urine output should reduce. The urine output should reduce. The urine output should reduce to the same 0.5 mil per kg per hour, but now for 12 hours now. Okay, should reduce but for 12 hours. And then for F, that's for failure. So now someone has now come with failure. So what do we put on failure on the creatinine? So creatinine failure stands for someone comes in with increased creatinine levels about 3 times, or they present with creatinine which is more than so equal to or more than 4 milligrams per deciliter. Okay, but at least you have to know that more than 3 is for failure. Okay, then for urine output, under failure, the urine output is usually less than 0.3 mils per kg per hour, but this happens in 24 hours. Okay, so in 24 hours, or someone just have anuria, so they just have anuria for 12 hours. You can still call it as failure for 12 hours. Okay, so someone comes with anuria for 12 hours, you can still call it as failure. Okay, so that's basically the most important things about the RIFO criteria. Then under the L, that's for loss. So under loss, of course, there should be just a persistent acute renal failure, which is complete loss of renal function for more than 4 weeks. So loss is when there is a persistent acute renal failure, so complete loss of action for more than 4 weeks. So someone comes with more than 4 weeks of renal failure, then you have to know that they are now at loss. Okay, then we also have E, which is just the end stage. So E is for the end stage renal disease. So end stage renal disease, there's nothing much to talk about here. Then you also have another criterion which is known as the Akin classification. But good part on the Akin classification is that, so Akin classification. So the Akin classification, you have to know that it has stage 1. So it has stage 1, stage 2, and stage 3. Okay, but these stages, they correspond to the RIFO, but they just respond to the R and the RIF. So the stage 1 responds to the risk, then the stage 2 responds to the I, which is the injury, then the stage 3 responds to the failure. That's the Akin classification. So it's just stage 1, stage 2, stage 3, but just the same RIF. There is no loss, there is no end stage. So that's the Akin. They've just removed the LE, but the RIF is just the same criterion which we use. Otherwise, that's the end of acute kidney injury, and that's all. Okay.